Welcome back to the All Ass No Gas education series. Today, we're talking with the man you all want to hear from, Dr. Stephen Ayres, all about polyps. It's Polyp Day. But before we get started, Maggie.
Yes, we just wanted to give a quick shout out to some sponsors: Shields, Sparrows and Arrows Tattoo, and Bozeman Food Co-op. Let's do it.
What is a polyp and where do they come from?
A polyp is a little growth inside the colon. If you could imagine that the inside of the colon is like a little carpet. The little carpet is made up of cells, and the cells die and regenerate. And when they regenerate or grow, sometimes the control of how they're growing just goes awry, and the little growth gets bigger and bigger, and it looks kind of like a wart or a skin tag on the inside. But they can continue to grow, and they can actually turn into cancer. Now, we believe that most cancers actually come from polyps, but not all polyps turn to cancer. But because of that, when we find polyps, we remove them, and that helps reduce the risk of cancer.
Can you prevent polyps?
I wish we could prevent polyps. There is some data that taking aspirin can help reduce the risk of polyps, but it's not a universal reduced risk answer. And the answer to that is generally we can't prevent the growth of polyps. There isn't a prescribed medicine, there isn't a diet, there isn't a lifestyle that you can say, if you do this, you will have fewer polyps.
What are the different types of polyps?
The main polyp that we're looking for is called an adenoma. And polyps that are of that characteristic are called adenomatous. The reason we're concerned in that is because the classic transformation from tissue, from a polyp to cancer, comes from adenomatous colon polyps. Now, not all adenomas turn to cancer, but they're the ones that are most likely. Adenoma polyps that are most likely to turn to cancer are the ones that are larger, advanced polyps because of size, or if you have lots of them, initially like 6 at a time or more in your colon, you're more likely to have that done. And then under the microscope, we can see changes that would cause that polyp to be considered advanced. It's advanced if it has little tiny microscopic fingers called villi or villus changes, and it's advanced if it has what's called dysplasia, high-grade dysplasia, which is a further transformation toward cancer. That is how we think about adenoma colon polyps. Now, the next category is called sessile serrated polyps. And those are polyps that look a little bit different. They're often flatter. They sometimes are covered with mucus. They're harder to find, and they're often on the ascending or the right side of the colon. Now, a subset of those polyps is called hyperplastic polyps, and most hyperplastic polyps are of no consequence. So we typically ignore them unless there's some sort of familial or genetic disorder that's quite rare. The sessile serrated adenoma polyps are different than the typical adenomas we talked about. And they also go to cancer, and sometimes they can go to cancer more quickly than the adenomas. So we're quite aware of that flat polyp, and we try to find them and remove them.
What interventions can be done if you were going to remove a larger polyp?
One of the ways what we're asked frequently is, well, how do you actually take a polyp out? What do you do with that? And it kind of depends really on the size of the polyp. So initially, if you have a little tiny polyp, just like a little pimple, if you can imagine, we just take a little biopsy forceps that has a clip on it and pluck it off and send it to the lab, and that's all that's needed. For polyps that are a little bit larger, we can use a little snare. It looks like almost like a little hangman's noose that you can pull in and out of a catheter that you pass down through the colonoscope. And you can snare the polyp and just snip it off, and then we use suction and pull the polyp back into a little canister and send it to the lab. The larger the polyp is, the more work it takes to get it off. And when we see larger polyps, we think about the safety in removing them in terms of not allowing for bleeding during the procedure or putting people at risk for bleeding afterwards. And then we also are concerned about perforation, not putting a hole in the colon when we take the polyp off. So in order to do that, in some polyps, we actually inject a colored sort of gel-like substance into the tissue, and it raises it up on a little fluid pillow, almost like a little egg. And then we can snip off the polyp without cutting deeply into the colon. Then in order to try to help reduce the risk of bleeding, we can put little metal cliplets, almost like a suture, onto the polyp and to the polypectomy site and prevent the bleeding. And then when we think that we might have to come back and look at that area, or that the patient might need to have an operation, we can actually inject sterilized India ink into the lining of the colon. We call them tattoos. The tattoo can be seen with the endoscope or the colonoscope, or it can also be seen by the surgeon if they're operating from the outside of the colon, and that helps localize what they need to do.
Did you ever think you were going to be a tattoo artist when you went into this field?
I'm still trying to spell mom.